ecstasy 0.4%, and the cocaine 0.4%. In overall terms of drug use, we have our best estimates around 269 million people have taken at least once a drug in the last year, equivalent to 5.4% of the total population, 15 to 64. But if you look at the problem drug users, which nowadays we're called the people suffering from drug use disorders, we speak about 36 million people who are suffering from such problems. So the real problem is this order of magnitude, and the order of magnitude is 0.7% of the population, 15 to 64. And this is clearly where the biggest focus is and the biggest focus should be. Now, in terms of how have been the trends, overall, you see in terms of prevalence rates, yes, you see changes, but they are not really important over the last decade, around 5%. The best estimate is now 5.4%, but you see the big error margin. So honestly, based on this, you cannot say much about the trends. It seems to be an increase, but nothing dramatic in terms, and the same applies to the problem drug users. And this is now in the terms of the number of people there, because the population has increased. You see also, it seems that the number of people who have used drugs has increased. Why I say it seems? Because the error margins are very big, and the estimates actually do not allow for making a firm statement. Even so, personally, and using at other data we look at, we think it has increased, but the data as such only tells us there's a big error margins around these estimates, and a firm statement you cannot do at the moment. Another issue is the drug, the disability, the DALYs, disability adjusted life years lost, and here we speak about 40 million lost on average a year, and 585,000 people dying from drugs. Now, is this much? Is this little? When you're speaking about the COVID crisis, until when we launched the World Drug Report, there was still around 400,000 people died from COVID. Now it's 650,000 people. So now we're slightly above. At the time it was launched, it was slightly below that numbers. We see all the big story and the crisis we have because of COVID, but basically nobody speaks about the every year crisis we have on drugs, around 585,000 people. This was the years for 2017. Now, having said this, put it into comparison. The deaths related to tobacco, 8.1 million, alcohol, 2.8 million. So the drugs account for 5% of all deaths linked to the deaths of psychoactive substances. When it comes to the DALYs, we have tobacco 213 million years, alcohol 108 million years. So drugs are 12% of all DALYs. It's important, but we still have to remember legal substances, alcohol and drugs, tobacco and alcohol cause much more of a harm than drugs at the global level. Now, when we look for what are the substances what people are dying of, or people the life years lost, there's clearly one group of substances which dominates, and that's the opioids. Opioids dominate this, so around half of all DALYs at the global level lost, half of all life years lost are due to the opioids. So our focus clearly in terms of harm has to be and should remain on the opioids. Now, the opioid crisis, we look at the United States. We had basically 3 waves. We had an original wave of an opioid overdose crisis. Then we had a second wave when we had heroin overdose and people dying from heroin because people shifted from the pharmaceutical opioids into heroin. And we have a third wave of the last few years, which has basically the shifting to synthetic opioids, particularly to fentanyls. Fentanyls mixing, and you see, while overall opioids have been rather stable, the pharmaceutical opioids the last few years have been stable. Heroin also has been in the United States starting to stabilize, and oral opioids has even marginally declined in 2018. There was an ongoing increase in the synthetic opioids, and particularly it's the fentanyls which have been responsible for this. Here we see the seizures. The seizures are particularly in North America, and you see the big increase in seizures in the United States. And the second one is then Mexico. far less is Canada. But also in Europe, the overall trend has been upwards over the last couple of years. Nonetheless, when we take now the seizures, 2014, 2018, we see that 98.9% of the fentanyl seizures were in North America and 0.6% in Europe. So the problem of the fentanyls is still a North American problem. Even so, also in Europe, we see an upward trend over the last couple of years. In terms of why is it? Why is this the case? Here we have for the North America, the heroin profits, the production costs, and the retail. So of course, you make a lot of money once you buy heroin and you sell heroin. But if you compare this to the fentanyl, it's almost peanuts. Production costs of fentanyl is lower than of heroin, and the retail, what you can get from the market, is much higher. So the overall profit in the system is much higher. So there's a big interest from trafficking groups to shift away from the heroin into fentanyl because it's there where you make the money. And the fentanyl crisis, what we had in North America, was not a demand-driven crisis, it was a supply-driven crisis. It was a decision by the traffickers to move into fentanyl to make the profits there. And why is fentanyl so problematic? Fentanyl as such is 50 to 100 times more potent than heroin. And they have some of the fentanyls, like carfentanil, 10,000 times more potent than heroin. This means a small mistake can be deadly. A small mistake can be deadly. And people who produce these fentanyls are not, it's not the chemical industry, it's not the pharmaceutical industry, it's individuals who very often have very limited information, limited abilities to work on these products, and thus the risk of dying from fentanyls, from wrong mixtures of fentanyls, is extremely high. In parallel, we have the problem of the tramadol in Africa, particularly Western Africa and in Northern Africa. We see also that here the issue is again particularly a supply-driven issue because the prices of tramadol have been much lower than of other opioids, or not particularly much lower than the prices for heroin. There have been some good news. Tramadol got under national control in India, which used to be the main supplier of tramadol, in 2018. As a consequence, there was less of the big shipments to Africa. But this was the good news. The bad news was that immediately other substances were sold as tramadol on African soil, and sometimes which were also dangerous in creating additional problems. And the underlying problems, what we say in a second, is why are people so much into tramadol? It's very often because the access for people who needed opioids just isn't there. There's a big problem of access to pharmaceutical opioids for people who need it, which is not there in Africa. And I come back to this in a minute. So overall, what we can say, we have too little and too much of the pharmaceutical opioids for medical purposes. Too little in the developing countries and too much in a number of the developed countries. So 12% of the global population has access to 90% of the global pharmaceutical opioids. This is a very uneven distribution. We see where it's high. It's high in North America, extremely high. It's high in Western Europe. It's high in Australia and New Zealand. And everything else in the world is clearly below the global average, and it's particularly low in Africa and particularly low in South Asia. And it's very clear people also die there. People suffer from pain in those areas, and they don't get the medical medication, the pharmaceutical opioids, which they would need. In terms of the trends, we see actually about something positive. Initially, you see the big increase here in North America of the opioids, and then the last 2 years, a clear decline. It's positive. Still, it's clearly above the average, but the trend as such seems to be positive. For Europe and Australia, you see an increase and rather stabilization thereafter. For developing countries, for a number of those, you see an increase, which actually, again, is positive. Having said this, we still have areas like South Asia, Africa, but also Central Asia, where the per capita consumption is extremely low and clearly far too low, and we even don't see the increase which would be needed. So people who would need the preparations to suffering from pain don't get this medication. Now, we analyze also in the World Drug Report the reasons for this. I don't want to go into it, but a number of legal regulatory systems, supply management problems, healthcare system providers, all face problems and are not properly there to so that the people who would need the drugs actually get the drugs. Next problem is just the overall view. We go to individual drugs, global seizures. Now look for the opiates. Here, the classical trafficking is from Afghanistan along the Balkan route. You have trafficking from Myanmar to China, but also to Australia. And you have trafficking in the Americas from Mexico and to much less extent Colombia, to North America, to the United States. So it's really three quite separate markets which do not have much in common. They are in parallel. They're not in addition, they are in parallel. This has been the case for many years, and this continues to be basically the case. In case of cocaine, there's only one production area. This is South America, the Andean region. The biggest shipments continue to be from Colombia to Central America and then onwards to the United States. But we have also ongoing shipments to Europe, either directly or via Africa. And again, you see areas going to many other parts. So we have a proliferation of drug trafficking routes. We have seen this over the last couple of years, till the big amounts are to North America and to Western Europe. Even the other markets are increasing. The biggest shipments are still these two main markets. And of course, South America itself is a big market, notably Brazil. When it comes to the ATS, amphetamine type stimulants, we see the biggest seizures continue to be methamphetamine, followed by amphetamine. In terms of cannabis, the biggest seizures is cannabis herb, followed by cannabis resin. Now, on terms of production, what we see here has been basically an upward trend. Even so, for the last couple of years, we've seen some positive signs. In Afghanistan, the area under cultivation has declined by 20% in 2018 and by 38% in 2019. So it's something positive. Why is it not changed into production, or not so much into production changes? Simply because in the previous years, we had very bad years of yields in Afghanistan. These years, the yield has normalized, come back to normal levels, and thus we don't see the impact on the production side, even so the area under cultivation has strongly declined. In Myanmar, we also see a decline in the area under cultivation in the last 3 years, and also even for Mexico, we have data for 2016-17 and 17-18. Also there we see a decline. So there are some positive signs on the opiate side. Nonetheless, the opiate level of production is extremely high, and so there is no shortage on the market. Just the opposite, the stocks are still full, and so the market continues to be completely supplied by opiates, also by heroin. In terms of what is the importance, we see average production of opium continues to be dominated in Afghanistan, 84%, followed by Myanmar, 7%, and then Mexico, around 6% of the total. When we look to cocaine, we have seen actually a record high in terms of production in 2018. Having said this, we also have some good news. The good news is in 2018, for the first time, there has been a small decline of the area under cultivation in Colombia. In 2019, even a stronger decline. So something positive in Colombia to see. For Peru, unfortunately, we don't have new data. And for Bolivia, in 2018, we had a small decline of 6%. In 2017, the last year where we had comparable data, 70% of the area under cultivation was Colombia, 20% Peru, and 10% Bolivia. In terms of ATS market, we've seen a massive expansion of the market. ATS seizures increased fourfold over the 2009-2018 period. And meth seizures, which is the dominant seizures, we see the in blue or slightly green, they even increased sevenfold from 2009 to 2018. So the biggest increase on the ATS markets was methamphetamine. Here was the most important expansion. But we also looked at the different regions, and there we see a very different pattern. While amphetamine continues to be the main ATS in Europe. We see North America, it's methamphetamine. The same applies to Southeast Asia and so on. So look for the regions. It's a very different pattern from region to region. NPS, we have 282 substances under international control, but we have some 950 substances which were identified at the markets globally. So in the last couple of years, we've seen a clear increase in the number of identified NPS. So there's 3 times as many substances which are not under international control than substances that are under national control. So on the NPS, this is something to keep in your head, in your mind. At the same time, the market is very in a state of flux. So the substances come in and substances come out. So on average, we had around 500 substances newly emerging every year on the market, but many substances disappear and other substances come back to the market. We also see one problem is really the harmful opioids, which has come onto the market. This is the particularly the fentanyl analogs. They are the most problematic NPS, what we're seeing, and those numbers have increased in recent years. At the same time, we have seen that countries who have done putting the psychoactive substance, the NPS, under national law, there seems to have been a containment effect, at least in some countries. If we look at the example of here first of the UK, you see methadone was controlled in the early 2010s, 2011, and you see a massive decline in the amounts of methadone you find on the market. Also NPS in general, there was an NPS law in the UK, and since then we have seen a clear decline in the overall numbers of people who used NPS in the UK. Having said this, there are also some exceptions. So, for instance, ketamine has again increased in recent years. Not the same everything, but overall we see there has been a positive effect. The same now we see for 12th grade students in the United States. We see synthetic cannabinoids. Once they have been put under control, their use has declined. The same applies to ketamine and to cathinones in the US, a clear decline in the use over the last couple of years. And this is something positive because these substances, particularly cathinones, are really dangerous and can be very dangerous. We also see an interesting example of a comparison of Austria and Germany. Both countries speak the same language. They had a similar drug problem, but in terms of NPS, Austria introduced NPS legislation first in 2008 and later in 2012. And in Germany, it took a little more time. Only in 2016, the NPS legislation was introduced. And we see Austria in 2015, 0.1% of the population. In Germany, 0.9% of the population were using NPS. Otherwise, similar drug problem, but on NPS, a very big difference. Once Germany introduced it, the level remained stable. No decline, but at least it remained stable, no more increase. But overall drug use increased in Germany. Yeah. Next, cannabis. Cannabis. On cannabis. Sorry. On cannabis, we see a decline in the quantity seized of cannabis, which, as such, is positive. The problem is again here that this does not mean a decline in the cannabis use. We just see the opposite. It's simply because of change in regulations, you see this decline in seizures. Now, we look at cannabis use in Colorado and Washington, where cannabis was first legalized, and you can see there was a clear increase in both Washington and in Colorado. There was also an increase in the United States as such, but the increase was much more pronounced in Washington and in Colorado, where you saw the legalization. What is more problematic, partial use in the United States increased, the number of partial users increased over the last decade by 68%, the past month users by 81%, but the daily users by 124%. So it's really daily users who use it every year, every day. This has shown the biggest increase. But there are some good news. The good news is there had been expectations that once you're going to legalize cannabis, the young people will massively go into cannabis and use it. Fortunately, this has not materialized. What we see is actually a decline in cannabis use both in Colorado as well as in the United States over the last couple of years. So this was in contrast to the overall trend. Cannabis use among youth actually has declined. Okay, of course, for youth, it has not been legalized. Legalization only starts at the age of 21. So where it has not been legalized, but it's interesting, there was no spillover from the general population to the youth population. So this was a very positive trend. On the other hand, emergency room visits, a clear increase, hospitalizations, a clear increase. In terms of the age groups, we see the increase among the 18 to 24, the 26 to 34, the 35 to 64, not among the young, 9 to 17, it was rather stable. However, in terms of hospitalizations, all age groups increased, and this again a phenomenon we don't completely understand, the difference between emergency department visits and hospitalizations. Hospitalizations increase across all age groups. Public safety outcomes, in parallel to the legalization of cannabis, the persons who died under the influence of cannabis from a car accident has clearly increased. It used to be around 6% 2006, and it's around 18% in 2018 in Colorado. We see also an increase in property crime and violent crimes in Colorado. So the idea that once you legalize cannabis, crime will decline. Unfortunately, this did not materialize. And the same also we see to Washington. Both property crime and crimes against persons increased after legalization. Not saying because of legalizations, but there was clearly no positive outcome in terms of an overall decline in criminality. But what you also see around the illegal market for cannabis continues. Here we have the data for Canada, and in Canada it says that still around 40% of the cannabis users get the cannabis from the illegal sources. The positive sign, it used to be more than 50%, only in 2018, in 2019, it already fell to around 40%, but still 40% is a lot. And why? Because cannabis on the illegal market is still cheaper than on the legal market. So it's quite logical that people, when they have an opportunity, want to go for the cheaper cannabis. The cheaper market is the illegal one, and they, as I said before, around 40% get the cannabis from this market. Now, the darknet, we have a long-term upward trend. We see a short life span of darknet markets, but we also see a temporary loss of confidence, which has occurred. But now everything has changed again with the COVID crisis. During the COVID crisis, the darknet has become very attractive again, and particularly retail trafficking via the darknet has increased. Now, in more detail, you see here the lifespan on average of a market has been just 8 months. And most of the markets who were active in 2019 were only started in 2018. So it's really a phenomenon very strongly in flux. In terms of the new users on the darknet, what we see, people who had never used drugs before, around 4% started using the darknet to purchase drugs in 2015. But by 2020, it was already 9%. So there is a growing proportion of people who never used drugs before, but once they discover the darknet, they get the drugs via the darknet and they use it to get drugs. So this is something definitely to watch out. The second thing what we are seeing is that the darknet remains a young phenomenon. So a third of the people who use the darknet for purchasing drugs just started doing this in last year. We have around 50% doing it in the last 2 years, and 2/3 doing it in the last 3 years. So, so there are not many people who used for a long time the darknet. It's just very recently that most people have started to use the darknet. In terms of the countries, basically all countries see an increase in the use of the darknet. We saw a temporary decline here, 2018, 2019, but again 2020, starting with the COVID crisis, the darknet explodes again, and there is far more use of the darknet for drug purchasing purposes. Nonetheless, having said this, we see that the key consumer markets, the legal markets, the key consumer markets, United States and European Union, is still far bigger than the sales via the darknet. So we are just speaking the darknet accounting for 1.2 or 0.2% of the combined US and EU drug retail sales. It is still a small market, but a rapidly expanding market. Now, overall, we have seen a global drug market expansion over the last couple of years. Over the last 2 decades, with all the problems we have, we can say probably around 30% more drug users between 2009 and 2018. The deaths have increased. We have the highest cocaine production ever in 2018, and we still have, despite some declines, abundant opium production. And we have seen the massive increase in ATS seizures. So what is the reasons for this? And one reason clearly has been simply population growth. So we see here population growth in developed countries was much bigger than in developing. In developing countries is much bigger than in developed countries. And we see all the drug use has increased much more in the developing countries than in developed countries over the last 2 decades. The global markets increased in complexity. We have new technologies like drones. We have multiple substances mixing. We have precursors, designer precursors, pre-precursors being used to circumvent rules. So far more complex than before. We have increasing use of polydrug trafficking, polydrug use. We have always new substances entering the market, and we have an increasing overlap between legal and illegal markets. This has been some of the consequences of the last 2 decades, what we see on the markets. This example you see here on the precursors. And the precursors for methamphetamine, it was very clear it was ephedrine and pseudoephedrine used to dominate. In the last couple of years, it's changed. Every year, something else comes onto the market. For some years, it was Apan comes onto the market. We have P2P onto the market. So it's become very complex. We could go for hours into this in detail, but just to say, it's a changing market very quickly, particularly on the supply side, reacting to changes in controls. Traffickers change and take the substances which are more easily available.
Thomas,
yeah?
Can we, is it okay to finish in just a minute or two so we can?
Just a few slides. Yeah.
Okay.
We have a vicious circle. We have a vicious circle of conflict, of limited education, unemployment, poverty, creating drug use, and drug use creating more unemployment, contributing to limited education, to conflict, and to poverty. So this is something we discuss in more detail, and we discuss it also for special groups, for women, sexual diverse populations, indigenous, aboriginal people, ethnic groups, immigrants, displaced persons, people in rural settings. Another issue we discuss is the development assistance. Development assistance, we have seen overall increase, but for drug control, we've seen a clear decline. Nonetheless, what we have seen is overall the seizures have clearly increased more than production, and some of it seems to be due to more international cooperation. So there's something interesting. Despite less money, there has been actually more cooperation and probably more seizures taking place, both on the opium side and on the opium and cocaine. In terms of alternative development, there's interesting discussions about differences of villages where alternative development takes place or not. In Afghanistan, for instance, security plays a big role. Government control plays a big role. There's a big difference. But also healthcare, where you have good healthcare, you have less drugs. Where you have bad healthcare, you have got more drugs. And similar stories for Myanmar. And we got drugs and violence. Drugs and violence, what we understand or what we analyze is the situation is very complex. It's not a clear positive correlation. It's different from country to country, from region to region, and we analyze this in quite detail, but I don't have the time to go into details. Now, last couple of slides is just the COVID crisis, what we have had. What we see in here is because of the crisis, there was initially a reduced opportunity to sell drugs and the shortage of precursors. The trafficking has changed, particularly everything which had to do with air transport has declined strongly. We also see, because of the border controls, some reduction in drug trafficking. And the bad thing is now that we see a decline in accessibility to services. And this is particularly for NGOs a big issue. When health is needed, much more needs to be done to prevent this from happening because drug users need the access to those services. What are the problems? The problems is we are expecting again a rebound of drug use. We also expect a shift to low quality drugs and the use of stockpiles. We see a problem in the rural populations, and also in the long run, once we're going to see more unemployment, we also expect more people to suffer from drugs, also being involved in drug trafficking. So the long-term effect is very negative, even though the short-term was actually a little bit of positive. Okay, I don't want to go into this, but what we studied in previous studies from 2008, financial crisis, is the change to more harmful patterns of drug use. It's the use of cheaper drugs. It's a way towards more injecting of drugs, and it's a problem when government budgets decline. Then particularly less is being done to assist people who have drug problems. Last slide before I finish is on the darknet. On the darknet, what we have seen is a clear increase in sales at the retail level, not at the moment at the large quantities. The wholesale level actually has declined, but retail sales have clearly increased, particularly in the case of cannabis. That's it. I hope I informed you about some of the main points of the World Drug Report, and I'm happy to answer any questions. Thank you very much.
Thank you so much, Thomas. And I mean, it's a huge, this report is such a huge undertaking. It's like you said, 6 booklets, you know, so much information in there. So it's so, you know, really appreciate you trying to pull out the key messages. The actual presentation itself, Thomas, will it be okay if we share that with the VNGOC members on our websites? Thomas, is that okay?
This is fine. This is great. Yes.
Okay. Okay, great. So that answers one of the questions we have in the chat as well. So we'll make sure that those slides are available to you, and obviously as well as a link to the World Drug Report itself, which is now on the UNODC website. So without further ado, I would love to give the floor now to George Odalo, who's the founder of the Slum Child Foundation in Kenya. Slum Child Foundation are a non-profit making organisation. They work with children, women and girls in the informal settlements in Nairobi in Kenya. They work to address drug and substance use, poverty, illiteracy, and the provision of essential skills to empower the most at-risk people living in the slums of the city. George does incredible work helping the children in those slums. We're really pleased to have him speak today and to talk about how the World Drug Report has supported their work and the work that George has been doing to bring a civil society voice to these debates. So without further ado, George, can I hand over to you? George, are you there? I think you're still muted according to my screen.
Good. I hope now you can hear me.
Perfect. Hi, George. Welcome.
Yes, thank you. Thank you very much for the opportunity that I have been given to share the World Drug Report, the civil society perspective. I thought I would be good enough to share my screen, but I think Sarah will help me in doing that because I can't find where I need to do the screen sharing, my presentation, but Sarah can help me do that. But as she does that, I can still read through as she's bringing that to the screen. So as you have mentioned, is that we are an organization that, we have an ECOSOC status with the UN, and we started sometimes back in 2008. We are working with children, women, and youth in Nairobi, and we address a number of issues, some of which you have mentioned, and yeah. Then the second point is where I want to dwell on a lot is the importance of World Drug Report to our organization and civil society at large. One, it helps us know which areas in the field of prevention, treatment, and harm reduction that we can upscale, because the World Drug Report does a lot of information collecting, and then it's up to us to see how are we going to upscale this information that we will use or we are using to promote evidence-based intervention, whereby we are looking at the best practices that have been shared by the UN that are evidence-based and how we can put in, because everything needs a comprehensive approach, and you cannot just do a comprehensive approach if you don't bring other actors or other areas into the picture. Two, it also helps us get the required data for our work that help shape the work that we are doing at the grassroots level. And it also, the work that we are doing in connection with the donors and the people, I mean, the beneficiaries and the donors. So once we are able to know that, it becomes very easier for us to even challenge the government, to even challenge donors, that these are the areas that we would want to upscale. These are the information that are there. And we really, really feel that if we are able to get this, we can be able to take it to the next level. I can use a good example of where we are working. I mean, a lot of children are very much affected with drug abuse. If you go to Uganda, where my mentor, Rogers Kasire, is, a lot of young people have been affected with Njaga. They call bang Njaga. And if you look at different countries within Africa, they have been affected. So if we are not able to get this right, I mean, whatever we are doing will be close to zero. Again, it also helps us know the emerging trends in different parts of the world. In terms of prevention, what is it that is coming up? What is it that is in treatment? What is it that is in harm reduction? So that we can know if this is the problem, this can be the best solution. And I remember in one of the statements, Jamie said that it's not when we want to address drug issues in the world, it is not a one size fits all, because the complexity or the complex issues in Africa, or the problem in Africa, cannot be compared with the problem in Europe and the US and different parts of the world. So once you're able to know what is happening in what area, you know what is emerging and how to come up with the best solution. Now, apart from that, we have the World Drug Report. So as civil society, what are we planning to do with this? One, we are looking forward to disseminate this information or this data through all avenues that are available to us. We know most of the state parties come to Vienna, make commitments, but you cannot follow that commitment if you don't have something to prove that this is the problem and this is how you want to use it. So we are also looking forward. I know the Kenyan government, they have the World Drug Report, but after we've gone through the gaps that are there, we are looking forward now to go and ask them, can you honor your commitment? Because this is an emerging trend. You made a commitment that you will support this in this area, and this is what we want you guys to ensure that you stick to. And the other thing is that it also helps us share this information. As the presentation has been done, once we are able to get this information, we get to know how to disseminate this in a layman's language, because most of the people don't read these books. We have good books for the World Drug Reports and all that, but most of the people, especially, let me talk about the slum setup. These people don't have that time, and they don't have that time to read through the World Drug Report. So if we can't have people who will be able to disseminate this in the simplest language that they understand, it will be very difficult. The same information that we normally get. I remember last year when we were interacting with our children in Korogocho, we were able to share with them what is there, the number of people affected, the number of families, so they get to know that this is a big problem that if we don't start changing now, it's very difficult for us to change it in the future. Then I will talk about the challenges. Challenges of that. It's not easy for us to achieve whatever we've mentioned. There is no commitment. Third parties need to commit, and just not commit, fulfill their commitments, because you can commit but there is no action, so it becomes very difficult. And that is why we as an organization, we are looking forward to ensure that we will push the Kenyan government to ensure that they fulfill what they made commitment to during the ministerial segment, during the UNGAS. And not only that, but even regional bodies like African Union, EU, and the rest, we'll just try and ensure that we give them that, not a bad approach as we are known as civil society, but a positive shoulder that they get to understand that this is also part of helping them achieve what they want. Inadequate data in terms of interpretation, dissemination, in all the field remains a big challenge, especially in Africa. So it's a big challenge because at times we come up with interventions, but we don't have inadequate data that can help us do that. Again, this comes back to the issue of treaties. Most of the state parties come, they sign the treaties, it's a party, it's everything. But but after some time, there is no achievement. I mean, you can't achieve certain things that you've committed to because there is no full-time commitment. So we need to commit and implement. And when it comes to implementation, it needs a comprehensive approach where is involved to ensure that it works not only for the best of the country, but for the best interest of the people that we are serving. I think I'll end my presentation at that. And thank you again for the opportunity, and thank you for everyone who was listening.
Thank you so much, George. And yeah, really appreciate that. And, particularly appreciate the comments you're saying about, the need to communicate what's in the World Drug Report, because there's a lot of information in there. It can be very technical. It can be very difficult to understand what the key messages are. And I think the work that your group do and what other groups do is really important to communicate these key messages to the groups on the ground. So thank you again, and thanks for everyone for bearing with us with the webinar. I hope you found it interesting. We do now have some time for questions and answers. And as I said before, we welcome you to write your questions, whether they are to Thomas from UNODC or to George from the Slum Child Foundation. Please do write your questions in the chat section. So the first question we have, which I'll read out now in the interest of time, and this one is for you, Thomas, so just so you can get ready to answer. So it says, this is from Federica Bertaccini. I apologize with all my name pronunciations today, if I've got that wrong. But it says, thank you so much for the extremely good and very interesting presentations. While the presentation of the World Drug Report provides information on youth, it unfortunately did not provide any data related to the consumption amongst women. In one of the booklets addressing this specifically, we are in dire need of sex disaggregated data in drug consumption and related crime. Many thanks in advance for addressing this very important topic. So, Thomas, if I can hand over to you to answer that one.
Yes, do you hear me?
Yes, yeah.
Okay. First of all, many thanks for this question. Just for you to know, we will do an in-depth analysis of the disaggregated data on men and women in next year's World Drug Report. This is already clearly foreseen. Just for you to also know, in the 2018 World Drug Report, we had a booklet just on drug use and women. It's not this year's, but the 2018 World Drug Report. Of course, things change, but the basics, I think, are very much, I assume, is still valid. So anybody who wants to look at it, 2018 booklet 5 is on drug use and drug supply. And here, women drugs has been the title of this booklet. We will look into details. Of course, we address in part of the World Drug Report, also as in particularly in booklet 5 this year also, the issue of women, but the more detailed, more in-depth analysis you will find in the 2018 World Drug Report, booklet 5. And next year, I promise you, there will be far more on disaggregated data on men and women, and data. This is already fixed for us. Thank you.
Okay, thank you very much. So flicking through the other questions we did have one question on the coverage of need of international substances, but I think that actually came before you presented those slides. So I think that has actually now been answered, but there was another very interesting question on the same topic, which I'm just trying to find now. So under UNODC's work, under the drug policy, it was stated that there will be control of opiates for medical consumption. Can you say a bit more about how UNODC hopes to achieve this? What is UNODC doing to address that? You mentioned it as the dual crisis, too much and too few. What is UNODC doing to address the too few?
Yeah, actually, this work in our split up of work is the work of the INCB, of the International Narcotics Control Board. And they have already highlighted this issue for a couple of years. And we kind of took it up as well. I think it's so much important to bring it to the general public. Even the INCB has written about it. It's really the INCB who has to do the work because every country has to do the estimates. And the estimates come to the INCB, and the problem is that many countries do not do them accordingly, appropriately. They are afraid and give too little estimates. And we can't force a country to put in a big number. But by writing this World Drug Report, I think we hope to have alerted the authorities worldwide to say, please look at your methods, how you estimate next year's consumption of opioids. Because it cannot be that people in Africa do not suffer from pain and only people in North America suffer from pain. That's definitely not the case. That's not true. This has to change, and we're definitely promoting this. But the actual work-wise, it has to be the countries themselves, and this is being done in cooperation with the INCB. And I know the INCB has been working on this for years, but we see the trends are there. The trends are going in the right direction, but still at the current level of trends, it will take decades and decades of people still having to suffer until the situation has improved. So I say, on one hand, we want to make people alert of it. This is why we wrote it in the World Drug Report. And second, we also, I think, need the support of NGOs strongly to make this point, to repeat it, that this is the case and that is a situation which is not endurable.
Okay, thank you, Thomas. And we have a similar question actually for you, George, if you want to come off mute, if you can come off mute now. It's from Tanya Shimeno. Again, apologies for pronunciation. It says, congratulations on your work. Do you also monitor the access of children to opioids for medical purposes? And it says in the question, 2.5 million children in serious health-related suffering, most of them living in lower middle income countries. Is that something that you also focus on with Slum Child Foundation?
No, okay, the answer is no. But at the same time, the government of Kenya, through the national agency, NACADA, they have an interagency coordination team that does that. So we get most of our data from, because once they collect, they share it with NACADA, and then once NACADA gets that, we are able to get it. Yeah, that is how we get it. And I think in most cases, African countries get this information from the parent ministry, the ministry that does issues related to substance use, drug use prevention, treatment, and harm reduction. So the government has that responsibility to do it, because from the civil society point of view, it's a bit expensive, especially in low middle income countries where resources are inadequate. Yeah.
Oh, thank you very much, George. So we have a couple of other questions here, which I think are more aimed towards you, Thomas. And they're related to the COVID-19 element of this conversation. Obviously, that is the livest issue right now in all of our work. So one question from Crispina Okello: there's a reduction in drugs production due to COVID-19. What do you think should be done to ensure that production and consumption remain low even after the pandemic has been contained?
First of all, this is an extremely good question. So thank you very much for this question. Second, hello?
Can I just ask everyone who's not speaking, other than Thomas, to please mute their lines and keep them muted? Thank you. Over to you, Thomas.
I
think it's Alex Mbweme. Thank you. If you can keep your line muted. Thank you very much. Thomas.
Okay. The problem, as I said before, the problem is that we are going to see, with the economic downturn, far more unemployment, far more problems. And so we are poised to see an increase. So what is really needed is that the governments do not cut the budgets, on prevention, do not cut budgets on treatment, do not cut budgets on harm reduction, and because they are sort of the classical things which might be cut because of the financial crisis most governments have at the moment. So the idea is really to say, please, and this is our urge, do not cut these funds. Do not cut funds for hospitals, for NGOs. Do not cut these funds because they are extremely important. Otherwise, at the moment, the problem might be lower, but it will not be lower in the midterm. In a few months, in a few years, it might raise drastically. So it's really important, and this is our outcry, what we have in this COVID chapter, to say, please, and our policy implications chapter, please do not cut these funds. I think that's the most important thing we can say at the moment, because yes, as long as people cannot go out, cannot go to a dance party, you will have less ecstasy use, of course. But once, and it's been at some stage, all these restrictions will be lifted, and once they are lifted, you can see definitely there will be an increase again in drug use and in participation in the drugs. So all the government programs in place, the NGO programs in place, need to continue and cannot and should not be cut.
Okay. Thank you very much, Thomas. We had one last question, which was also on COVID. I'm going to read it out, but I think you may have already addressed some of it, Thomas, anyway. But it's from Dr. Katie Lowe, who says, I'd love to hear any further thoughts Thomas might have on how COVID-19 may affect the various drug markets and drug use. So yeah. I think you have addressed some of that, but just a last chance if there's anything else you wanted to add on that one, Thomas.
Where we see, so the information what we have so far has seen that we have seen actually an increase in cannabis use, which is quite interesting in the COVID period, while cocaine use seems to have partly declined. The recreational drug use, so the ecstasy, has clearly declined. So it has been substance specific. We also have seen, interestingly, an increase in benzodiazepines use during the COVID crisis. So the few studies what we have seen so far, but the problem is, for the time being, these are few studies, and it's not yet that they are comprehensive. So it will take us for another year or 2 years to really answer this question. Once we get the data, we can compile the data. Normally it takes 1 or 2 years until we know what really has been the case.
Okay, thank you. And one last question which just come up, and I think this will be the last one that we take. Again, it's one for you, Thomas. Thomas mentioned that population growth in the developing world is leading to increased drug use amongst the young in those countries. Is there an emphasis on drug prevention programs in the school-based populations in developing nations to prevent the problem before it takes hold? There is a successful collaboration between UNODC and Lions International. And so I should have said this question is from Anthony Paradiso from Lions International. There is a successful collaboration between UNODC and Lions International on the evidence-based Lions Quest Life Skills program that deserves mention. So over to you, Thomas, on that particular issue.
Okay, just in general, yes, what we have seen, the increase in the last couple of years has been stronger in developing countries. We have seen there has been programs from UNODC, but also from the WHO, partly in cooperation with UNODC, to help developing countries on prevention, and also in very close cooperation, in general, with close cooperation with the NGOs, because there's really a need for the NGOs to participate to do prevention work worldwide, and to be the people on the ground who knows the countries much better than anybody knows far ahead in a tower in a big building.
And there's just one more I do want to take. It's from Rogers Kasiri in Uganda, and I've just got to try and find it. It keeps, oh yes, because I think this really brings us back to the reason why we're here as NGOs and the engagement that we want to continue to have in this. It says, thank you very much, Thomas, for sharing the information. Is there room and I assume this is within the World Drug Report data, is there room for NGO reports? And can one extract specific countries' data from the World Drug Reports or the website that you have, the data website?
Sorry, I apologize. I did not really understand the question.
So with the data collection that you have, is there room within that for NGO reports and NGO submissions?
Okay, when we have, let's put it this way, we are collecting data from all sources. So if we get data from NGOs, they are most welcome. And we also, once they are done in a scientific way, methodological way, we definitely would like to obtain them. So if they could be handed to us over, we would very much appreciate this. They will definitely be taken into consideration, notably as in many countries, the information what we have is very limited. So the more information we can get, in particular from people on the ground, can be extremely useful. So if there's information and available and it could be shared with us, we would very much appreciate it. And it would definitely be taken into consideration in writing up the World Drug Report. Yes.
That's excellent, and that's a really, really useful invitation to end on. And the last part of Rogers's question was, is it possible to extract data for just one country from the World Drug Report or from the website that you have?
Yes, you can, but the idea again of the World Drug Report is not to have country-specific information. We have the seizure of country A, we have the prevalence of country A. You can put the things together. There's all we have in the annex, we have statistical annex with country data, so you can find the information. But I think the real interest of the World Drug Report is to put this into context. We are not writing the information about one country. It's not a one country report. It's a global report. So to know when we get the data, when you get the information, is this 5% or 1%? Is this much? Is this little? 5 kilograms or 1 ton? Is this a lot or is this nothing? So to get the idea, and I think for this is the World Drug Report very useful. So people to analyze the data, what you have in your own country, to see to what extent is your country ranking high, ranking low? Is it making progress, or actually is it doing much worse than other countries? I think for this it's very useful and it can be used, but it's not something you put in the country. Well, yes, you can put in the country and you see what has been written about a specific country, but you won't find it for all 192 countries in the world.
Understood. Thank you so much, Thomas. So with that, I'd just like to finish up saying big thank you once again to our speakers, to Thomas for presenting the World Drug Report so excellently, to George for presenting the NGO perspective as well from Kenya. Thank you so much for joining us. To Mirella and the whole civil society team for helping us to organise this. And also a big thanks to Sarah Perker, who's the VNGOC program officer in Vienna, who's been working behind the scenes to set all of this up. So thank you very much, Sarah. Just to finish up, just a few things. This video from the webinar will be available online. The slides will be available online. Please do check the VNGOC website and our social media to find those. And Sarah has also included a link in the chat box to a survey. Because this is the first time we've done a webinar like this, we'd really appreciate your feedback, things we could do better or things you'd like us to do in future webinars. Please do just take a few seconds to fill in this survey and just let us know your thoughts. We would really appreciate your input. And just the final word for me, I mentioned at the beginning the NGO marketplace that we have, which is the database we're trying to build of NGOs all around the world working on drugs issues. We did a very quick analysis of the 200 plus people who registered for this webinar, and only around 10% of them were actually their organizations were registered on the NGO marketplace. So I really do encourage anyone who's on this call who wants to engage more in this work and wants to communicate the work that their NGO is doing, please just take a few minutes to visit the marketplace. Again, the link is in the chat box, and visit the marketplace, set up your NGO with a profile. It's so easy to do. And that opens up lots of possibilities for future collaboration and communication. So please do that if you can find the time. So with that said, thank you so much everyone for joining us. I hope it's been interesting for you. We will be repeating this in Spanish tomorrow and in Russian on Wednesday. And then all of those videos will be available on our website for you to watch. So thank you very much for joining, and we hope to see you and speak to you soon. Thanks. Bye.
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 Thank you.